I'm just going to be giving you a brief PowerPoint on superficial temporal artery ultrasound. So basically, temporal arteritis, which is what we do the ultrasounds for, is just a type of giant cell arteritis. What we're doing is we're looking at the superficial temporal artery here, and it's just basically an extension of the ECA. It's one of the terminal branches of the ECA, and it's got some parietal and some frontal branches. There's a lot of variation in the anatomy. It's a little bit difficult. This would be something that you would rarely see, which is a patient with obvious temporal arteritis where they've got this big thickened cord-like vessel like this. I guess you'd see this in more elderly patients that have got quite thin skin. Once again, this is the anterior branch of the superficial temporal artery, and it's all thick-walled. Basically, it's a granulomatous inflammation or vasculitis involving small and medium-sized vessels, and in this case, the temporal arteries that we'll be looking at. And you can see it. Basically, you end up with this very thickened intima like this, swollen intima. It's inflamed, and it can actually get to the point where it closes off the lumen in quite severe cases. Affects people predominantly of European ancestry. It's got quite a big female to male prevalence. You can see it in some of the other vessels of the body as well. The thing that's quite important from our point of view doing these scans is that it can involve the ophthalmic artery. So if the patients aren't treated in a timely manner, they can actually go blind. A lot of them will present with eye symptoms. They can present with diplopia or amaurosis fugax, which is like a temporary loss of vision in one of their eyes. And it can also just involve focal segments of the artery, as well as longer portions. So that can be a little bit of a problem when you're doing the biopsies on the arteries, because they can end up with these what they call skip lesions, which are just little short segments of the artery that are actually involved, and if they don't biopsy the correct point of the artery, they may actually misdiagnose it. The American College of Rheumatology has these 5 criteria, and they need 3 of these to be filled for them to make a provisional diagnosis of Juche A or temporal arteritis. So most of your patients are going to be over 50, and as I said, they're strong female to male preference, and they might come in with a new onset of a localized headache. The temporal artery will be tender. The ESR, or the eosinophil sedimentation rate, is generally raised and over 50, and also their C-reactive protein will be raised as well, because it's an inflammatory condition, and as well as the abnormal histology from the biopsy. Some of the other symptoms they might get, you can read them all there. There's some funny ones like jaw claudication and scalp necrosis, hair pain. You can see the gentleman down the bottom there. His condition has got to the point where it's occluded one of the arteries, and he's actually got necrosis of the scalp. It's been supplied by the anterior branch of the artery. And as I mentioned before, they can also have eye symptoms because of the fact that the ophthalmic artery supplies it. A lot of the patients will also have polymyalgia rheumatica, and 40 to 50% of them will also have that coexisting with GCA. The biopsy is always thought of as being the gold standard, but as I mentioned before, you can have skip lesions. That's where ultrasound can be useful in telling them exactly where the thickening of the artery is, and can show the extent of the disease. One of the articles I was reading in preparation for this strongly suggested doing bilateral biopsies, not just on one side, because it can quite commonly just affect one side and not the other. So here's an MRI. You can see the vessel just here, nice little thin wall around the vessel, so that's absolutely normal there. And you can see this is the ear. So So that's what we like to see as a normal vessel. This is an abnormal vessel with temporal arteritis, and you can see all of this here is edema around the vessel, and this is actually what you'll see on the ultrasound, which is the classic halo appearance, which is where you've got the really sort of thick wall like this. We work on about 0.6 of a millimetre as being the upper limit for our thickness. Some of the other articles I read were saying 0.7 of a millimetre, but generally 0.6 I think is the go. Here's just another couple of examples here, this sort of donut looking main temporal artery with the edema around it. So basically the protocol we use, we look at the main temporal artery and the anterior and the posterior branches. I like to start in transverse. You can follow the main temporal artery along, and you're looking for this hypoechoic halo like this around the vessel, which is analogous to this biopsy specimen just here, and that's also quite comparable to what you're seeing on the MR. So you saw that on the MR, and we don't see the edema around the vessel like that. This halo here is pretty much almost diagnostic of Juche A when you see it like that. And we also use colour Doppler to look for stenoses in longitudinal, because the vessels will be sort of thick-walled and normal, thick-walled and normal. So you're looking for areas where there's a more than 50% increase in the velocity. And as you'll see with some of the other pictures I've got coming up, you'll end up typically with a very high resistant flow because the vessels are tapering distally because they're so thick-walled. Some of the pitfalls, as we see with this gentleman here, he's got quite a lot of hair, so he'd be quite difficult to examine. They can also have a large accompanying vein, which can be a little bit confusing. I just use a little bit of compression, and the veins will compress and the arteries won't. And you can just see here, like this is a normal artery here, and you can see how small the wall is there. And although it's probably a bit of a no-no, I use the colour Doppler to help guide me to where the wall is sometimes, and just make sure I'm not getting any excessive bleeding into the wall that's obscuring it. The main superficial temporal artery can be quite tortuous as well, so that makes it hard to measure the wall in transverse. You just need to make sure you're following the vessel. Lots and lots of different variations in the anatomy, which can make it quite difficult. Artifacts, so you can see here, this is obviously quite thick-walled, this vessel, but possibly because of overlying hair, we're just getting quite a furry sort of image here. I like to use quite a low dynamic range so that I get a nice contrasting image, which will hopefully get rid of some of that. So here's a normal ultrasound. So we've got main superficial temporal artery, and I just measure the wall anteriorly from there to there, and you can see that's 0.026 of a centimetre or 0.226 of a mil, so that's well within normal limits. Once again, just using the colour just to guide you, you can see like quite a thin little wall there. Nice Doppler here with lots of end diastole telling me that there's no distal problems with the vessel, and that it's quite easy for the blood to get up. It's quite a low resistant bed. And here's the posterior branch here. Once again, the wall just here from there to there. And here's an example of an abnormal vessel here. So this is the wall here. It's got a big sort of hypoechoic donut around it. And you can see that's 7.2 millimetres. Even just yourself looking at that, you would know that that's not normal. And on the other side here is just a normal vessel. Here's an abnormal Doppler, and as I was saying before, like you can see the big thick-walled vessel here that's obviously not very happy. We've got quite a high resistant Doppler signal because it's going into a high resistant bed a little bit further down the track. And here's a normal vessel with lots of end diastole. Obviously this is quite happy, it's going into a much lower resistant bed. nice example of Juche A without the colour on here, and you can just see this hypoechoic thick wall. So you can see this hypoechoic thick wall along the vessel here, and if we could see it a little bit better, you could see it's a little bit lumpy as well. It's not sort of uniformly thick. Here's our colour Doppler here of the main branch, and once again, losing our end diastole, quite a high resistance signal. Find quite often it's really good to use a standoff with these. Not always, but it will sharpen up the image for you. You end up sort of losing a lot of that sort of early reverb artifact because these vessels are just below the skin, as you can imagine. So you use the standoff, it just gives you a little bit of distance between you and the probe. And I think this is the same patient that you could see from the previous image, and sure you'll agree that looks a lot nicer, that image there. We're getting a lot nicer image of the wall and the morphology of the wall there. Here's a transverse view using the standoff again. And I just take the same principle as when you're measuring the gallbladder wall with these. When you're measuring your gallbladder wall, you're always trying to measure the more superficial part of it. You don't want to measure these bits around the side. Just another couple of examples. Here's our main temporal artery here with a standoff, nice hypoechoic donut around it. Using the colour Doppler again, see the hypoechoic wall around the outside. A little bit of a trick with this as well that I found out when I first started doing them was I made the flow go away quite a lot by actually compressing too hard. Even though it's an artery, it's so close to the surface, if you're pushing a little bit too hard, you can actually make the flow go away and make it look like there's no flow there. And this is the same patient, and I actually deliberately did this to try and show that I could make the flow stop, and I did by pushing too hard on the vessel. After we've examined the main artery, then we go and look at our posterior and anterior branches. So you can see here's the posterior branch. We generally follow up this way up to the parietal area. And you can see this is an abnormal one again, quite high resistant flow, no end diastole. Here's our posterior branches, one with the standoff, one without the standoff, just showing you the difference. Here's the anterior branch, and this is also an example of Juche A. Here the wall of the vessel is quite thickened. You can see it's just over 6 mils, 0.6 of a mil there, but that's still abnormal. And you can see in longitudinal we've got our Doppler and thick wall vessel there. This was something that I got off one of the articles I was looking at, and it's a little bit of a flow chart. They were basically saying that if you do your colour Doppler and you see a halo, basically go straight to treatment, because the earlier you can treat these patients, the better. The longer you leave it, the more risk there is of the patient developing blindness if they've also got the ophthalmic artery involved. And you can just see like there's just a few other steps they go through there. So basically, once it's been confirmed either clinically or with MRI or with biopsy or with ultrasound, the treatment's corticosteroids, and that will, over a couple of weeks, bring the arteries back to normal. And when you rescan the patients, which we have quite a bit, but PA after they've been on treatment, they come back and the arteries look absolutely normal after they've been on steroids for a couple of weeks. When we were doing them in the beginning, they would ask us, they would send the patient back and say, we want you to put a little line, along the line of the artery where you think it's thickest so that we can biopsy. So I think that is pretty important. Just from what I was saying, about the skip lesions as well, they can just blindly go in and biopsy it, but they mightn't actually keep the bit of the artery that's affected.